Hello and welcome to the EU-India People Summit. This is the 8th day and the final day of the summit. And today, while India and EU are engaging in discussion in Porto through a virtual EU-India diplomatic summit, at the People Summit, we want to take account of the COVID situation unfolding in India and parts of the world, and what needs to be done, what is lacking in the response, etc. So with this, I would like to hand over to the moderator for the current panel, Umair Khan, who's a doctor himself from NHS. Please, Umair.
Thank you, Ritumra. Good morning and welcome to the EU-Indian People Summit panel discussion on fighting with COVID, the challenges, the successes and failures, and the lessons for policymakers. As humans, the COVID pandemic has touched us deeply, physically, emotionally, and mentally. And there's no denying that it has posed many challenges to governments, to policymakers, to citizens, and to existing healthcare systems in different parts of the world. And they're grim reminders of the pandemic raging on in India, from personal stories, and I'm sure the panelists would have a lot of those personal stories from mainstream media and from social media. And we have seen and heard from in the UK, the panelist here, and from the EU and the US and other high and middle income countries that it wasn't easy for anyone at the start, where we saw New York and London in the first wave. You'll remember how they did struggle at that point. In India, the story is very bad. And the good thing about one slightly good thing about the pandemic itself is how quickly lessons were learned, how different countries ramped up their healthcare resources to treat those unwell. And in the first wave, the complex lockdown decisions, and I'm hoping some of you would touch on that, the focus on vaccination then to ensure a degree of protection for the population in the second or the third waves that were predicted. And in India, it is going through the worst of the pandemic. The cry for hospital beds, for medicines, for adequate personal protective equipment, for ambulances is everywhere. And for me, the most distressing has been the cry for oxygen. For patients, the cries for oxygen get feebler as they sink, but for surviving family members, they just keep reverberating those cries. And then they become the stuff of nightmares for families. And so that is all very troubling. And we have seen extraordinary headlines where the courts have stepped in, the Supreme Court having to order a government to say, you need to deliver oxygen to these hospitals. Or the High Court, in a very rare outburst, saying that, I just quote there, how non-supply of oxygen to hospitals is a criminal act and not less than a genocide by those who have been entrusted to supply oxygen to hospitals. So the EU India People Summit, as highlighted in their initial messages on the websites, is a non-partisan, non-bureaucratic festival of ideas with an aim to shape the vision for a future of democratic, secular, and rights-based collaboration between EU and India. I'm delighted to be joined by the experts on this panel from both UK and from India, as we discuss the challenges faced in UK and Europe and in India, and speak of the successes and failures and the road ahead. My name is Umair Khan. I am a pediatric critical care consultant in Edinburgh, in Scotland, and I have been very interested in public health and passionate about the equity of healthcare access to all and I have an obvious bias towards the NHS system of healthcare. So that's my disclosures. And I will introduce the panel members in turn as we open the session by asking each panel member for opening statements on their experiences on key topics with regard to the pandemic that their own research and work has focused on. My first panelist would be Dr. Anant Maringanti, who is the director of Hyderabad Urban Lab, which is a multidisciplinary urban research center based in Hyderabad in India. He has done a lot of research on cities and urbanization in South Asia and has done remarkably lot of work on the effect of disease and poor health and the pandemic now within Hyderabad and the country. Dr. Maringanti, please give us an overview of your thoughts and on the short and long-term effects of the pandemic in the social context. Thank you.
Thank you, Dr. Umair. Can you hear me properly? Okay. So thank you for having me on this panel. Let me quickly introduce myself. My name is Anant Maringanti. I'm a geographer, and I came to geography through a series of other work that I had done as a journalist in many different locations across the country. In this particular instance, the question of health has been of interest to me, even as I think about cities, primarily because of the way in which it has impacted outcomes, other outcomes in lives for people. So one of the things that we have known consistently in cities like Hyderabad is that the costs of health, particularly chronic illness, is really, really terrible for a very large number of families. So in fact, when the COVID pandemic began, for us at Hyderabad Urban Lab, the real question was, who are the people who are going to go hungry? Who are the people who are going to be affected by COVID for the long term? Because we know that one little bit of a blip in their family income can push them into decades of poverty from which they just simply cannot get out. So as we began to look at this, we realized over time that a number of very important changes were taking place in the way we imagined our world. The first thing was that many of us had become very deeply aware of geography in terms of where is the disease, how do we trace it, where is it actually affecting people. And then even as we were struggling to figure out where are the diseased people, where are the sources of infection, we realized that we were actually looking also for people who are hungry. Where exactly are our hungry people in our cities? That's where it all began for a lot of organizations last year who were not actually concerned about COVID in the beginning. In fact, I remember many of my friends, activists, strongly arguing that in the name of COVID, we're actually killing people by hunger. So the argument was that we should not be talking about COVID at all. We should not be locking down like this. We should not be trying to control the pandemic, because that is actually going to lead to much more death than we are imagining. That's where it all begins, right? So we begin to see then that we are looking at locations, we are looking at pathways, where exactly are people moving, how are they moving? We are looking at logistical decisions about how do we reach help to people, because we found that literally thousands and thousands of trucks with supplies were being held up on roadways, and that was a huge problem for us. It was food, it was medicines, it was injections, everything held up everywhere across the country. Now, from that, we move into another period very quickly, even at that time, where we begin to see that boundaries become a huge problem, because as you move from one jurisdiction to another, the way in which people's mobilities are regulated is changing across the country. So boundaries become, jurisdictions become a huge problem. Even as we try to sort out this stuff, we realize that a lot of the work that actually needs to be done is no longer really being done by any single agency. It looks like the government is there, but it is the corporate houses which are jumping in to help. It looks like it is corporate houses that are doing it, but you realize immediately that it is civil society groups which are also jumping in. So what we realized was that within a matter of 2-3 weeks time, government officers, corporate officials, and civil society activists were all connecting across the country in all sorts of ways where it is impossible any longer to think in terms of a hierarchical government. That the central government would do this, the state government would do this, the local government would do this. All of those things basically become something that goes into the background, because the only way we can get things done is through these chance connections that you can make with people. And this was the second thing, the third thing that really became very important for us. And then we realized that we were actually looking at very short time horizons. That is, you are looking at someone who has to be moved very, very quickly in a matter of minutes into a hospital, and you don't have a hospital bed available anywhere. So this tremendously, dramatically shortened time horizons was something that we just didn't know how to think about, right? And this is not just at the level of moving people from one place to another, but also in terms of the kind of drugs that have to be developed. You don't have the luxury of taking 10 years to develop a drug that will work. You have to develop it in 10 weeks. You have to develop a vaccine in less than a year's time, right? So what kind of regulatory mechanisms, what kinds of trade-offs are we looking at? What kinds of ethical considerations that have to be brought into this? All of these things became issues. And all of this being handled in an immensely traumatizing circumstances. Like right yesterday, even as I was preparing to think about what to say in this panel, we had a 15-year-old girl sitting at home with one parent in one hospital, another parent in another hospital, and she desperately asking people to provide some kind of a help whereby her mother could be moved into an ICU somewhere. And for hours and hours, about 40 people were making phone calls trying to figure out how to make this happen, and all the time feeling horribly, horribly guilty that we are not able to make that bed available for a girl who is sitting at home completely paralyzed by fear that her parents who are in two different hospitals could be suffering. We have had conversations about volunteers calling up medical chiefs in hospitals and asking for an ICU bed and being told that, look, I have 6 patients connected to ventilators in this ICU. You tell me which one you want me to unplug so that I can accommodate your patient, right? You don't know how to handle this. We don't know how to ask people whether they have money or not, because a lot of people don't know how to ask. I remember in a number of conversations in Hyderabad where people kept saying that, look, we know that people do not find it easy to ask for help. So it is for us to go and look for people who need help. And that's a big challenge, right? So what we are seeing, to me, at this point of time, is a set of questions in which dramatically altered spatial horizons, dramatically altered temporal horizons are asking us to come up with ethical responses. And it is in imagining those ethical responses that we have to find our political responses as well, right? And that's what I think is the key challenge that we need to sort out. And I'm going to leave my comments at that very broad general level, because I want to take the time to come to the concrete questions in the next 2 or 3 rounds of the conversation. Thank you, Umair.
Thank you. Thank you. Already so much food for thought there. You talk about lockdown dilemmas, you talk about boundaries and jurisdictions, and hopefully a dismantling of the traditional hierarchies, and certainly, and the short time horizons. So yeah, certainly we'll come back to those after speaking to the others. I'm sure they would also want to contribute to the points that you've raised. So for my next speaker, Dr. Raghib Ali, who is an independent expert advisor to the UK government on COVID and ethnicity. He's done a lot of research on diseases in populations in UK, India, and the Middle East, and is an honorary consultant physician in the Oxford University Hospitals and with Public Health England. I'm keen to hear from him about the UK experience overall of the pandemic. And as you've seen, Dr. Maringanti has told us about the lockdown dilemmas. So over to you, Raghib.
Thank you, Umair, and good morning to fellow panelists, participants, and good afternoon to those who are joining from India. So I will kind of carry on from where Dr. Anant left off and talk both about the experience in the UK and the European Union and what maybe India could have learnt from those experiences. But the main point really is that every government, particularly in Europe and South America, North America, we've all struggled with these dilemmas over when and how much to lock down or to have restrictions on people's freedoms and movements, on schools, on employment, etc. And none of these were easy decisions. As Umair said, we've also all been, many of us personally affected by the pandemic. I mean, I served on the front line in both first and second waves. It's fair to say the NHS really did struggle at times as well, particularly in the second wave in January, where we faced something really unprecedented across many hospitals. And sadly, I lost colleagues in the hospital that I work at. I've lost relatives in India to COVID, as I'm sure many of us have. And it really brings home just how personal the experience of COVID has been to most people. On the issue of restrictions and lockdown and how that's affected the epidemic, what I wanted to show, I know time is short, so I'm not going to spend too much time to allow everyone to have their chance as well. But I thought it might be easier just to show some graphs of what's happened in different countries. So I hope you can all see that. So this graph is from a website called Our World in Data. And basically it shows 4 different countries the course of the epidemic. So we look at the United Kingdom first. We had, so these figures are are very much affected by the amount of testing going on. So if you look at deaths, it might give you a better idea of what happened across the pandemic. So you can see in the United Kingdom, we had a fairly large first wave about a year ago, and then an even bigger second wave over the winter. Across the European Union as a whole, a similar pattern. So a longer and bigger second wave. And the worst affected country in the European Union was actually Hungary, which in some ways has gone on to a third wave most recently. And Hungary is an interesting case in point because they had a very small first wave. They had a strict first lockdown, they closed their borders. And in common with many other Eastern European countries, they've had these really bad second and third waves, despite ongoing restrictions and lockdowns. And one of the lessons we learned from that is that lockdowns are only effective, of course, if the people are able and willing to follow them. And we've seen this in poorer countries as well, in low and middle income countries in South America, in Peru, for example. Despite very long and strict lockdowns, they've had very high death rates. And to an extent, the same applies in India. And if we look at Indian experience, it's difficult to compare exactly what's happened in India to the European countries because the amount of testing done has been lower. And so these numbers are affected by testing, they're affected by the way that deaths are certified. And they're also very much affected by the population age structure. So India is a much younger country than all the countries in the European Union. The kind of average age there is about 20, whereas in the EU it's about 40. So that has a huge impact on death rates as well. The country actually in the European Union that's done best is Finland, which hasn't really suffered from a second or third wave. And Finland, of course, is not a typical country. It's a sparsely populated country. It's somewhat geographically isolated, a bit like Norway and New Zealand that have also had success in tackling COVID. But they had early lockdowns. They closed their borders, and they've had very strict kind of controls on entry into Finland since then. There is another country where we have to look really outside the European Union to see a country which is densely populated and with a large population, to see that it is possible to control COVID without a strict lockdown, and that's Japan. And they have managed to avoid large first or second or third waves. And a lot of that is due to strict social distancing, mask wearing, and restrictions on mass gatherings. And unfortunately in India, going back to the experience of India, we can see that they did manage to keep the COVID deaths down in the first wave, much slower than was expected. And of course, that was partly due to lockdown, but lockdowns in themselves can only postpone deaths. Without a vaccine, it's inevitable that cases and deaths will return once restrictions are lifted. And unfortunately, and particularly in poorer countries where people don't have social security or a welfare state that can protect them, or furlough like we've had in the UK, lockdowns, of course, have severe health and economic consequences, particularly on the poorest in society. And the balance of harms from lockdown versus the harms from COVID are extremely difficult for policymakers to decide what's best. And so I think the main issue in India, of course, was that when restrictions were lifted earlier this year, social distancing and mask wearing and pretty much all kind of restrictions were lifted too close together. And these mass gatherings that we saw really have led to these super spreader events all over the country. Unfortunately, that's what we're seeing now. And of course, the other factor is the variants that have been at first caused havoc really in Europe with the so-called Kent variant, and now similar variants in India have also been shown to be more transmissible. And so a combination of lifting restrictions too quickly and too at the same time, as well as these new variants, have led to the current problems in India. I mean, the good thing is it does seem to be stabilizing now, and hopefully people will understand that that their behavior really is crucial to controlling the further spread of the pandemic. Just one final thing on restrictions. So you can see from this graph that different countries have had different levels of restrictions, but not hugely different. So even I mentioned Hungary. It has had quite a high level of restrictions for months, but despite that, it has not been able to control their epidemic. Even India still has restrictions. The UK, of course, is relaxing now. And the countries that have been more successful haven't needed as many restrictions because they've never had such a high death rate. And the final point is on vaccination. So the real solution to this is vaccination. That's the only way, because as I said, lockdowns only delay infections, they don't prevent them. And you can see here, again, why the UK has been successful in preventing a third wave. It really is because of vaccination combined with the restrictions. Hungary, although its share of vaccination is quite high, and you're seeing that their rates have started to come down now, but it needs to be above really 50% to see what we've seen in other countries like Israel as well. And you can see the EU is somewhere behind, but India sadly has a long way to go. And in India, the other point is, in regard to vaccination, is that the UK followed the approach of vaccinating those at most high risk first. So 99% of deaths occur in those over the age of 50. In India, the balance, of course, will be different. But it would be better to vaccinate those, particularly over the age of 40 in India, who are going to have the highest death rates. And I think going forward, that's where vaccines should be prioritized. So I'll stop there and look forward to this further discussion.
Excellent. Thank you. Thank you for highlighting those differences between the various countries, even in the lockdown decisions and the restrictions within that, and then the vaccinations. And we'll come back to those because the next speaker, Dr. Razvi, has also been very keen on the vaccination questions, and we will revisit that again in that second round. So Dr. Razvi is senior research economist at the Copenhagen Consensus Center, and she works on prioritization of policy options based on economic, social, and environmental cost-benefit analysis. Her research focuses on public health issues in India, including health insurance regulation and growth, and the impact of liberalization on the healthcare policy. She has also written a lot recently on, like I said, India's, shall I say, slightly puzzling vaccination strategy. And I hope she can touch on all of this in her opening remarks. Over to you. Over to you, Dr. Razvi.
Sorry, I was muted. Thank you. Thanks. And thank for this panel.
Right, we can't hear you.
Dr. Maringanti set the tone. You know, what of the COVID pandemic in India. it's reaching devastating proportions. We are % of the global burden. And yesterday we crossed, sorry. Can you hear me?
Yeah, now we can hear you better. Right. I think we'll get back to Dr. Razvi. So we'll go on to our fourth speaker and get back to Dr. Razvi in about 5 minutes. Dr. Aviral Vatsa, he's got a solid background in research, in medical research, and is currently working as a clinician, as a GP in NHS Scotland. And he's been very active in the current pandemic in increasing the common man's understanding of the infection and its effects and treatment options. Aviral is a good friend and is a co-founder with me of the Scottish Indians for Justice organization. And he brings an activist zeal to his efforts to improve the current situation in India. Let us hear your thoughts, Aviral.
Thank you, Umair. Thanks a lot, and a lot to the organizers for this People Summit. It's a fantastic effort, especially going in parallel about talking about challenges and solutions about the pandemic. So thanks a lot for that. As Umair mentioned, my keen interest for especially for today's topic is about communication in the pandemic. I would start by saying that miscommunication it costs lives. And that was the key for me to go after it. And what I early on last March itself, what I realized was there was very little information percolating down to doctors, to end users of any sorts, to public, to doctors back home in India. While here in UK, thanks to the NHS, thanks to some of the central bodies of doctors and scientists, we were getting evidence-based, even if not evidence-based, well thought through guidelines, evidence collected from around the world, and that information was sent to us on daily basis in huge chunks, and that gave the end appliers like doctors or healthcare workers of confidence that at least we have something to bank upon while we are taking those tough decisions, being on the front lines. Now, same goes for public. Public were totally confused as to what is coming and what not. As Anant mentioned, that there are so many discrepancies in the society, especially in India and also in UK. So it becomes really difficult for people to make sense of what is happening, what should be done, what should not be done. What happens if a president or a prime minister promotes hydroxychloroquine? Should we take it or not, for example? Where does the evidence lie? So from that background, I took it like to make some efforts in bridging the gap between what is evidence, what is known in the scientific world and medical world, and what the people are looking to know, and try to put forth in front of them in simpler terms. Now, the end users of information, as I said, could be healthcare workers, could be people, could be policymakers, could be people in the government. All people in different domains, they need information which is actually evidence-based. Because we all, at the end of the day, we all make a decision. We all make a decision to wear a mask or not to wear a mask. We take a decision to take hydroxychloroquine or not. And we also make a decision to do a lockdown or not. So all these things have the decision making has to be based on some sort of evidence, and that communication is for me the backbone on which a pandemic can be tackled. And then comes the point of infodemic, which WHO also highlighted big time about the sleuth of information, so much of information actually coming through the social media. It is the first pandemic wherein we have the digital technologies which are playing a huge role in good or bad, but in a pandemic. And we are doing the same. We are using the same technologies today to talk about it. Now, infodemic is good or bad information reaching to people, and in that, more often than not, it is the rumors, it is the non-evidence based, it is the opinions which reach far and wide. And then the fact, the evidence keeps on catching up with it. And there are so many examples that I mentioned hydroxychloroquine, remdesivir is another one which India is facing today. Plasma is another one. Even use of steroids is another one currently right now ongoing in India, about because the evidence is with the intravenous steroids, and we are talking about oral steroids there. And then it has its implications later on. We have already started seeing those implications in India. So this kind of information flow has to come from systems. Individuals can only do so much. A person like me with a very little reach can only reach 100, 200, and if somebody helps me, maybe 1,000. And if some big shot helps me, maybe 100,000 people. But here we are talking about 1.4 billion in India itself. So that has to come from systems, and by systems I mean a system of information which feeds into for healthcare workers, which feeds into for public, which feeds into for policymakers. Policymakers don't have to be only at the central level, because policies are made at district level, at panchayat level, at state level. So everyone needs that, and that system is sadly missing even today. And we can all gauge that, because there has been huge delays in updating the guidelines. For example, the medical guidelines, even I think AIMS took a long time to update their guidelines. ICMR has updated theirs after 6 months, whereas it should have been on daily basis. So that flow of information in a systematic way is another aspect I would like to highlight today. And quickly to finish off by saying that we have an example from UK. I don't know, we have still to quantify the impact of that in a good or a bad way, but what we look at how NHS has worked, how UK has worked, is that we have central bodies, also central independent bodies of scientists, of epidemiologists and others who look at evidence on daily basis, who have gone deeper, reviewed that evidence, and come up with credible evidence-based guidelines. And those guidelines are then sent on daily basis to doctors, to nurses, to physiotherapists, to cleaners in the hospitals, to everyone or to airflow department who manages the airflow of the system. So each and every aspect of healthcare has been provided some sort of evidence-based medicine, and that has gone a long way in stemming or increasing the trust of actions which NHS has taken, because they are based on some sort of evidence. Comparing in with what Ananthi was saying about India, because there is so much of uncertainty, even among doctors there is so much of uncertainty about treatments, because there is no scientific confidence in what is being asked of them, or what they know, in treating people, or in taking care of the people. So these kind of centralized bodies, even in NHS, to give you an example, I mean, there are colleges, there is a college of pediatricians, Royal College of GP surgeons. Each one of them further on adapted those national guidelines, and then adapted them to the specialty, what they should be doing or not doing in this pandemic. So everyone had a sort of an overall guideline, and then according to their own roles, they had something to hold on to as to how to act on in different circumstances. So, combining these things, I think they are the key. And I have been seeing that sadly in India, they were missing, and unfortunately, 1 year after the pandemic has started, they're still sorely missing. And from what I see, I don't have quantitative data. I don't know if we ever will have that. But what I see is lack of these systems are costing lives dearly, and not only lives. We will probably be seeing a lot of morbidity down the years because of that. I'll stop there, Umair.
Okay. Thank you for that. I know you have worked a lot on this, and we will be covering some of these aspects later. We'll get Dr. Razvi back, but before that, if I can get back to Anant, if that is okay. with a question about how you've highlighted the importance of people-to-people networks, and you highlighted about how there was that traditional hierarchies were no longer there, and how civil society played such a big role and is playing a big role. And I think for the Indian diaspora, the EU India People Summit for me is an example of that people-to-people network. How do you see the impact of these networks in improving the institutional processes or mechanisms, and possibly in influencing changes to government policies?
Thank you, Umair, for asking that question. Actually, that's something that is always on our minds, and I kind of agree with Aviral's point about policy actually not being made in one place. In fact, I would push that a little bit further and say that actually policy in India, as in most of the former colonies, is actually made in practice. You put something down on paper, but that thing that has been put down on paper as an intention, when it goes out onto the street, it gets implemented, and in the process, it gets completely reshaped. And I think that's what we are constantly struggling with. Because when we look at governance, when we look at success, we look at what's written down on paper, we look at the intention, and we check whether or not that intention has been realized. And actually, the intention itself gets altered in the process of implementation. So that's the first thing to remember. Second thing that is important, I think, is that at the state-to-state level, internationally, and between the supranational institutions and our nation states, we have actually not been very successful in forging very powerful tools and mechanisms for making big changes. We do have statements of intention, very pious goals and objectives, but we are not actually able to make those things come together in very powerful ways. I think the one thing where there is actually a lot of promise is in knowledge networks, is in people-to-people networks, whether we are looking at what is happening in India itself, whether we are looking at what is happening at the city scale, or we are looking at international scales. And let me give you a couple of examples of what this might mean. So in the last year, while everything was locked down, everything was shut down, while we were trying to figure out how to force governments and legislative bodies to think about what to do, we actually created shadow governments, virtual assemblies and legislative bodies in many different locations. And what these virtual legislative bodies actually end up doing is that without the restrictions of, without the rules of entering material into the legislative process, we can actually raise issues very freely and very happily in people's assemblies. So at the Hyderabad city scale level, within this Telangana region, we have something called Telangana State Praja Assembly. And what this Telangana State Praja Assembly does is to actually bring together all kinds of people, individuals, scholars, activists, and a whole bunch of activist organizations and civil society organizations. Sometimes we actually get corporate houses. Everybody comes in, and over 2, 3, 4 days, we actually set agendas that should be thought through. And I think that this kind of a crafting of a new public space, a new public sphere, is very, very important, because it allows us to find networks and connections that we hadn't even imagined. That's the first very, very important thing. That then actually leads to a second point that actually connects very nicely with what Aviral was saying about communication. See, one of the things that we have realized in the last 1 year in dealing with COVID in India is that we are actually going by a lot of what I can only call tribal knowledge. Tribal knowledge in the sense that you experiment, you try things, you knock things here, there, and by experience learn a few things. And we don't have the kind of very detailed advisories, protocols circulating, which are based on evidence, because there is actually very little data that is available in India, very little tracking. For example, I took my COVID first vaccine and then I had a breakthrough infection. I don't think anybody is tracking me. I don't think anybody knows why this happened with me, or what this might mean, or what might happen to me in the coming 1 year or 6 years or whatever. Nobody knows, right? It's only me and my diary that is going to be available to anyone who wants to do this as a research project. And so in that context, what has been happening is that a large number of people, medical doctors, people who have recovered from illness, journalists, all sorts of people have been writing about their experiences. And I think in that writing their experiences, both good and bad happens, right? Because you don't really have evidence-based information, advice. You don't really have any way of figuring out what to do in any scientific manner. So what you go by is how authoritative someone sounds, how confident someone looks, what kind of language or dialect is that person speaking in. So you find that there are a large number of people who can speak in dialects that people can understand easily, and they're very successful in communicating what needs to be communicated. So it's very important for us to figure out how we can translate what knowledge is available across the UK or in European Union, and figure out how to translate that into targeted communication packages for Indian audiences, and then see what we can do with that, right? It's those kinds of connections and networks that we need to think about. So as models, I think one very important thing for me is networks of knowledge and training and education that can come up. And two is the networks of somehow mimicking and experimenting with institutional forms, because without those institutions, we can't really solve this problem. I mean, I really do think that if you have another round of avian flu, you will have to take control of what happens at the airports. And that who takes control of the airport is a tricky question, right? Do you leave it to the national government? Do you leave it to the city government? Do you leave it to the airports authority? Or will the WHO be able to control those locations? And these are things that cannot be answered except by constantly talking about these things through these networks and shaping new sensibilities. Because ultimately, this part of this is about information, part of this is about evidence, but it's also about a certain kind of sensibility. Who really, what do you really care for? What matters to you as people? And it's those things that we need to work out.
Brilliant. And we're joined by Dr. Harun Qasim from Australia, another good friend, and he kind of agrees with you, Anant, in his comment about how centralized policy and governance could inform overarching priorities, but will be limited in their understanding of the local capabilities and needs. When you talk about avian flu, for example, and how policy and governance frameworks will have to be informed by the resourcing capabilities, wants, and needs of the local population, and in that highlighting the importance of institutions. So I'm hoping to get back to hear from Dr. Razvi. We're certainly keen to hear from her. So we'll hear from her first and then carry on with the session.
Thanks, Umair. Thank you. And apologies, everyone, for the break in Wi-Fi. Yeah, I'm not switching on my video, just keeping my fingers crossed that the connection works. I hope that's okay with everyone. So, my opening statements is basically looking at the policy perspective of this entire COVID-19 situation in India. It's reached devastating proportions, as everyone has commented on. We are contributing almost 50% of the global burden. Yesterday, we crossed 4 lakh cases and almost 4,000 deaths. More than that. And also these underestimations, and many into how we are handling this pandemic. Like Umair mentioned, there are critical shortages of hospital beds, oxygen in many locations, hospitals. People are dying for lack of oxygen supply. I honestly feel that the second wave is really a huge systemic failure on the part of the central government. As Raghib mentioned, they ignored things, they ignored evidence from other countries, went ahead with huge religious gatherings, relaxed public health measures, didn't pay attention to the insufficient vaccination coverage, and really ignored the presence of the newer, more transmissible virus variants, leading possibly to this huge surge in cases. In India today, and historically, the visibility of health as an issue has always remained very poor. And that is really, you can sense that just by looking at the poor allocation for public health in India. We've traditionally been spending less than 1.5% of GDP on health, in spite of decades-long.
Right, we seem to have lost connections. I think let me move on to Dr. Raghib Ali, who's spoken about the difficult decisions around lockdown. And as you're aware, in India, there was that early lockdown very early on with no preparedness, and led to harrowing stories of the difficulties faced by migrants. Migrant workers, and people like Harshmantar and Natasha have spoken about this very poignantly and eloquently, describing those stories. In the current situation, the massive spread, would you say that, you've commented on that, whether lockdown is important at this stage or not, and you've said about restrictions. But what I'm interested in as learning points would be, what was the UK decision making in terms of how you would support small businesses, for example, or private working people? How would you convince them that these restrictions are necessary, and the lockdown would not mean a loss in their own household budgets, for example?
So, of course, there is a difference between what high-income countries and highly developed countries can do versus lower and middle-income countries. So the UK was in the fortunate position that it was able to provide the furlough scheme, support to businesses, support to individuals, self-employed, which meant that no one was going to be short of food or to be thrown out of their house or to lose many of them did not lose their jobs because of that. And of course, the situation in India is very different. We don't have those types of social security schemes. And unfortunately, as we saw in the first lockdown in India, many people did lose their income. And many people, as Dr. Anant mentioned earlier, were struggling just for food. And so I think the risk benefit of lockdowns decision making is quite different in India compared to the UK. Now, of course, there are things that central government and state governments can do in India, and some of them have done that to support people during the time of lockdown. But I would argue that the key really to controlling the current spread in India is simple infection control and public health measures. So going back to mask wearing, going back to ensuring that there are no gatherings more than, outdoors, for example, more than 30 like we have here, indoors no more than 6. These types of simple measures, which again they've been using in Japan, for example, where they haven't had a major lockdown, but they have managed to keep the epidemic under control, those basic hygiene and infection control measures. And that, of course, requires leadership from both central government, state government, religious leaders, etc. And sadly, that hasn't been evident, for the last couple of months. I mean, India, did become complacent. I think they didn't see what was going on in Europe, and that a second wave was inevitable. And so the people, of course, also became somewhat complacent, but it's not too late, to reverse that. And we have seen in many countries, even with higher peaks than India has at the moment, and that they have been able to get the epidemic back under control, including low and middle income countries. So I think there is a way out. I think the other point, which I didn't make earlier, but there was this feeling that maybe India was different. It wouldn't be affected because of previous because of previous exposure to other viruses, etc. And I remember even in the UK when I was giving talks to people from the Indian diaspora, they were saying, how come that Indians in the UK are badly affected but not in India? And to be honest, the main reason for that at that time was really to do with the different age structures. But it was simply because these viruses do move in waves, and just because the first wave had ended, as I said, there was no guarantee there wouldn't be a second wave, and unfortunately, we've seen that all too well in the last couple of months. So I think, as I said, going forward, I don't think a national lockdown or a severe lockdown, putting tens of millions of people out of work again, is the solution. It's really stressing those public health measures and using all arms of both public and private sector to get that message across.
Thank you. Thank you. Yeah, I can totally understand your points there. Moving to Aviral, there is a question that I'd like to take from Harun about, I mean, you can lead on that, and then Raghib, if you can comment on that. He asks, we'll also be very interested in the panel's thoughts on triaging and protocolized care in reducing the resource crunch and delivering standardized high quality care. And certainly I know he's leading on a project in Australia that has substantial evidence to support this. And with digital healthcare, that can enable the above and promote scaling of such a solution.
Yeah, thanks, Arun, for that wonderful question. And I totally agree there. I've been actually wondering that how come triaging is not a part of the strategy to deal with pandemic in India. And he's absolutely right. Triaging is one thing which can be fairly rapidly implemented, and it can straight away save lives. Now, many people in their own capacity, many charity organizations, etc., are trying to do it, and they've already shown that there is an impact of that, and lives have started. They have started to save lives. Again, even the triaging, it very nicely feeds into what we were talking about earlier, because triaging is a very structured thing to do, and that structure is to be created based on what evidence provides us, and there is plenty of evidence for that if we can inform people, if we can triage them into the needs of mild, moderate, severe disease, and then treat them, and then provide with the treatment which is apt for that category, then we are already talking about not only saving lives and mobility, but also reducing a huge impact on mental health. So and reducing panic. What I have seen in India is that even mild cases, moderate cases are panicking once they are positive, and then they are going to hospitals to organize their cylinders, to organize, beds for them, so on and so forth. And despite my few attempts with few of the patients that you can stay at home, you can be safe, they have ended up in hospitals with mild to moderate diseases. And that has increased the risk of not only for the patient, but also for the people around them, and not only for the patients, even people going for testing, people going for vaccination now. They are exposed to a bit more risks of catching the virus. And again, it comes back to the same thing, that governments are not talking enough about what are these different categories, what is to be done in what situation, so that when the panic strikes, people shouldn't have to run for information at that time. They should know what is to be done when SpO2 level, the oxygen level, drops below 95. It should be a clear-cut 5-step procedure that this is what you can do. It might not be apt for 100%, those 5 steps. It might be case-to-case basis, but those 5 steps should be able to save lives for at least 90-95%, and that can be done in a structured, triaged, evidence-based way. So I totally agree. Now, how to implement it? I think that comes back to the same thing. On an individual level, on a charity-based level, there is only so much you will be able to achieve. In all these things, it is about systems to implement it. I fail to understand why there is no national guidelines on that, how to, the triaging, just the triaging system, why the state governments are not implementing it, why the big hospitals, something like AIIMS, why they have not specifically come up with that, and so that's something remains to be seen, how to meet it. But yes, a collaborative effort what Harun has started, and to amplify that will be wonderful.
Very good. Thank you, Aviral. Raghib, do you want to comment on that?
So, I mean, in the UK, fortunately, because we have a central single NHS system, it is much easier to control what goes on, of course, at the national level. And unfortunately, our situation here was never so bad that we needed to use triaging, certainly not in the emergency department. What we did do here was to manage more patients at home, so to provide oxygen saturation monitors, as well as home oxygen for those patients that no longer needed hospital care. And that, of course, relieved the pressure on hospitals during the peak in January. I think in India, and I've worked with various hospitals in India, both from public and private sector, one of the problems I've seen, particularly in the private sector, is that those, of course, who can afford to pay, even if they have more mild disease, are more likely to be given a bed than those who cannot afford to pay and have more severe disease. And that's a very difficult problem to solve. Of course, for the government-run hospitals and the state-run hospitals, they should be giving priority to the most severe cases and managing people outside the hospital as much as possible. I'm not, fully familiar with what's going on the ground in terms of field hospitals, but they have been used with good effect in other countries because these really are temporary surges. It's likely, and God willing, that in the next few weeks this will, be much better than it is now. So these temporary field hospitals can certainly help as well. So it's a combination of things. I don't think there's any simple solution here, and of course, time is very short. But both in the UK, we saw the Nightingale hospitals were established within a matter of weeks, and in China, and I'm sure India is capable of doing the same. And they can be quite small scale as well in each, town and even in suburbs of cities, etc. So I would suggest that's an urgent need at the moment.
Brilliant, and certainly we will talk about this a bit more. I'm just keen to ask a vaccine-related question to Dr. Razvi, because I know she's been working a lot on that. Are you back? Yeah.
Yes, Umair, really sorry about that. Yeah.
Go on.
Yeah. So at a time when, a very prompt and equitable COVID-19 vaccination drive is of really crucial importance, the Indian government has, I would say, think, abdicated its responsibility to not just its own citizens and population, but also to the entire world. It was surprising that the government chose to depend on just two suppliers, the Serum Institute and Bharat Biotech. What was even more surprising then was it allowed them to set their own prices. And if that was not enough, there was even a differential pricing allowed. So the manufacturers could now set prices for the center separately, the state separately, and the private players sector separately. The logic behind this move is very difficult to understand. What I would have expected as a committed and responsible government, what they should have done, that they should have incorporated a single payer model, with the government being the single buyer, trying to get the best possible deal from the manufacturer, getting the vaccines and then distributing it in an equitable manner to all the states. That's not happening. And, the vaccine strategy, the vaccine liberalization strategy, which was rolled out by the government end of April, that actually had two very important outcomes. The objective was definitely to supplement the central procurement, but limited to 50% this time to the central government. But also it was decided to charge different prices to different players. So what was even more surprising was then the Serum Institute went ahead and then decided to announce different prices to states and private hospitals. The incentive, the price the private sector paying is much higher. So obviously the incentive then is to, sell to the highest purchaser, not to the other purchasers. What this means is the manufacturers are not incentivized to sell to the states. And the other outcome of the policy was that it allowed the private hospitals to set their own prices. So right now you have, the price range of about 900 rupees to about 1500 rupees for a single dose of the COVID vaccine across the private sector hospitals across the country. So, that really is kind of unfathomable. The policy kind of bases itself on the premise that this will incentivize vaccine production, but because of the dual nature of distribution, this immediately leads to an inequitable system, right? Where the rich who can afford to pay, whereas the poor are left out of the vaccination drive. The government in the union budget, which it propagated this year, 2021, it had set aside rupees 35,000 crores for a COVID vaccination strategy. Even if it purchases vaccines for the entire population, the entire eligible population, that's about 850 million adults. That would still cost them less than that entire 35,000 crores. Why couldn't the government have just come out and said, that we are spending this money, we are buying the vaccines doses, and we are providing the vaccine free of cost across the entire population? That is what I would have expected it to do. Leaving finances aside, why central procurement is also preferable is because, as I said, it leads to a far more distribution of vaccines. So you know that the states which are poorer, the population which is more vulnerable and cannot afford to pay for vaccines, will also get the vaccine dose regardless of whether they have the ability to pay for that or not. In the current circumstances, with this pandemic situation, it's important that everyone vaccinated. It's not enough if the rich and the rich get vaccinated. It's not enough to provide herd immunity for anybody. And that's the reason that I think it's important that free vaccinations for all has to be the strategy going forward. And in that in that regard, the US TRIPS waiver comes as a good signal from the US government. And India, I think, really needs to look at issuing a compulsory license for the COVID-19 vaccine that would definitely incentivize production, if not distribution of the vaccines. And the EU, in that sense, which has been kind of a roadblock as of now, that really needs the European Union support that at the WTO. That's what I'd like to say. Yeah.
Excellent. And Alina and Ritumra and Indu, I think when we're talking about action points or learning points, I think Saleema's, Dr. Razvi's point there about how we need to put some more pressure, some pressure on this thing about liberalizing, taking the lead from what the US has done to see how vaccines can be available to everyone free of cost. And the question, I think, that naturally follows from Dr. Razvi's talk there, I'm just going to, actually, Alina, can you ask your question and mute and ask to the panelists?
Yes, of course. Thank you very much for allowing me to say
I would maybe ask Anant to take the lead on this, and then the others can respond if they need.
Of course. So my question comes from reading the news yesterday, the day before, and seeing that the Indian government has restricted NGOs' abilities to handle oxygen, to provide medical care, etc. And especially in Kashmir, this is detrimental, according to the local population as well as commentators, because a lot of healthcare is provided by NGOs. This has then therefore been described as possibly even genocidal. The Indian government, on the other hand, alleges that this is to curb the black market, to curb the hoarding of oxygen, which is also a legitimate problem. How does one tackle that hoarding of oxygen without it becoming genocidal, and what is going on in Kashmir with that basically banning?
Alina, actually, the answer to that question is very, very simple. When does hoarding happen? It happens when you have a severe short supply. And I think our real problem with most things in India right now is a very severe short supply of everything. We have a short supply of vaccine. We have a short supply of steroids. We have a short supply of remdesivir injections. We have a short supply of oxygen. Now, the issue is that increasing supply is not easy, but governments need to be seen to be doing something. And so what they do is to manage their image by trying to take very strong, or what appears to be very strong, action against organizations which are supposed to be looking like things which are actually damaging their images. So it's basically an image management thing, for the simple reason that this is not going to stop the informal markets that have emerged in supply of oxygen across the country. This is not going to stop the informal markets that have emerged in the supply of remdesivir, whose prices have shot up something like 30 times what it actually costs, 30, 40, 50 times, right? That kind of surges happen simply because we don't have enough. And that's one of the things that I was saying at the beginning, right? We haven't thought enough ahead of time. We haven't thought about the logistics. So you have governments which have requisitioned oxygen but haven't bothered to make sure that they have the cylinders to fill that in, haven't bothered to make sure that they have enough trucks to move it. And so you have all of these problems that are coming up everywhere. Now, the other issue that is coming up here is that, of course, it is going to be looking like a very, very genocidal attempt in Kashmir, but it's the same thing elsewhere. It's not as if it is a much better situation elsewhere, except that it hurts a lot more when you are looking at this problem in Kashmir. It hurts more there. Now, if we want to really tackle this, I think that we do need to have international pressure. We also need to have international easing up of a lot of regulations and regimes that have been in place. I mean, one very simple issue that we need to acknowledge is that for a country like India, doing a large number of gene sequencing tests means that our balance of payments is going to go into a problem, right? Because we do have to buy a lot of stuff from overseas. How do we handle that? To say that we are going to get a whole lot of vaccine and figure out how to pay for it is not easy. We don't have the money. And this is something that Raghib had raised earlier, right? We don't have enough surpluses to play with. And therefore, what happens actually is that there is an internal competition, and these internal competitions are always settled politically. So which region gets more, which community gets more, which group gets more. And in handling all of this, an international image is a huge problem. And anything that is not completely in our control in shaping the narratives for managing the image is an issue, right? And so you have actually NGOs which are really struggling now, right now, not just in handling oxygen, but in getting equipment for oxygen concentrators into India and getting them released from the airports, because we don't have customs clearances, right? Somebody donates it to me. My new latest FCRA, Foreign Contribution Regulation Act, makes it impossible for me to send that oxygen concentrator to another site because the law doesn't allow me to donate what I have to somebody else. So we have all of these problems which come with politics, and we don't have easy answers. And the only way we can do this is actually by building those new public spheres that I was referring to earlier, right? And I think that this is important for us to build with this, because these kinds of questions are also important for climate change, which is just the other thing that has been hanging on our head for a long time now. And it's time it has taken on that urgency. So we need to think about how we can internationally and globally organize against these things. And it's not an easy answer, except that we have to go ahead and do it and see.
Thank you. Alina, then another, so Anant, you're talking about the short supply of oxygen, short supply of remdesivir, a short supply of the other drugs. Sitting here, for me, it is also a very short supply of empathy from the government. And I think along with all that, and while I'm passionate about the NHS and the socialist aspect of it, it has a lot, for me, it has a lot to do with that no society, that mission statement at the start from the founders about no society can legitimately call itself civilized if a sick person is denied medical aid because of lack of means. And that empathy, I think, and how do we build up pressure internationally for governments to display that kind of empathy, where Alina talks about possible genocidal situations where oxygen cylinders and oxygen availability is poor. I'd like to go to Aviral and in a minute, but Alina, another action point then, from a personal point of view, from what Anant has mentioned about the custom regulations in oxygen concentrators, We as a charity in the UK, the Mahir Group and the Deccan Medical College alumni are working with charity in India, Access Foundation and Sahayata to transfer 400 oxygen concentrators next week. And I'm just worried that people have donated crowdfunding, and if it's going to just stay in the customs and not get released, and custom duties on that, which is all donation, that is going to be really heartbreaking. Right. So, Aviral, we talked about how Raghib has mentioned about how high-income countries have this luxury of healthcare and socialist healthcare models. I know you've worked a lot with the Delhi government's plans of the Mohalla clinics, and we've seen examples of how education schools have been set up that have really improved the standard of education. Can you elaborate on how is that a model that can be adapted by other cities, for example, other state governments?
Thanks, Umair. Well, just to clarify, I have not worked with the government, but I have observed those things very, very closely, and have been fortunate enough to know a few things from inside out. And I think because I just want to talk about a few things which Anant has touched upon, and even Raghib has touched upon, and going back to, I'm going to start again from triaging thing and get to answer what you just mentioned, because I think they are all interconnected and might also touch upon what Elena just mentioned. I'm getting back to triaging because it is not something which UK or NHS developed during the pandemic. It is something which is inherently systemic in the NHS way of dealing with things, although it is not always visible like so. To give you a quick example, even the GP setup we have in NHS, where everyone is registered with one GP of their area, is a kind of a triaging thing, because the GPs will triage which patient should see the specialist at what level of urgency, when they have to go, and so on and so forth. Which means that there is a controlled flow of those people towards the specialists who need urgent health care. And that is basically what triaging is: who needs what level of healthcare, and we assign it. So it's a systemic development which has been going on for years and years now within NHS. So much so that even when I'm sure, Umair, you do it all the time. Even when you go to your night duties or any duty, first thing is there's a meeting to discuss about which patients are more critical, how many beds do we have, should we do surgeries depending on how many beds we have. No, that planning itself is a part of triaging. So that is so inherent in the system that we have just extended it to the pandemic, and we have seen good results. And that precisely is what has been missing. Now, coming to the system bit back, what you asked about, Umair, is that we don't have a system which we can call a system of healthcare in India. There was an established system, right after independence, wherein there was from district level to even village level dispensaries, to district hospitals, to secondary care, tertiary care. But that system was not invested in. That system was not taken forward. So it has been left to from my point of view, I would call it has been left to collapse on its own, because it's not able to serve even the cares of health, the demands of healthcare, even in a peacetime, forget a pandemic. So unless we address that, I don't think it is even possible to expect that a pandemic can be dealt with in an equitable way. And it's not only a matter of high income or low income countries. Even country like US, which is supposedly a high income country, it doesn't have an equitable healthcare system. And depending on your income levels, people do suffer if they are on the wrong side of the health, of the diseases that they have to pay for the insurances and all that, so on and so forth. Their lives take a tumble, big time when they have to pay. So it is not only about a matter of how much money the government has; it's a matter of what vision they have. And you rightly mentioned, Umair, that if a society cannot take care of their sick, we cannot really call ourselves a civilized society. So from that point of view, I think the the Delhi's Mohalla clinic model is fantastic, but it's a very, very, very small effort. And it is the effort, it is the effort where it should actually start, which is what we call here the GP clinics, whereas the clinics are in the community dealing directly with the patient, so that the secondary care pressure load is reduced. And it has shown dramatic positive effects for healthcare, and also for saving a lot of funds for the government, because end of the day government does end up spending a lot of money not only on healthcare but also the consequences of that in loss of man working hours, quality of life, and so on and so forth, so many indices which we all know of. So they started with the Mohalla clinic, wherein they are like GP practices in the community, covering I think around 10,000 people per clinic. That was at least the goal. And then there was another attempt to make a bit of secondary care clinics, wherein a bit more specialized, bit more inpatient care can be provided. And then there was the tertiary care. They have a lot has been invested in it. And they, again, a step further from that is that now the government in Delhi has started with the vaccination campaign, but which is again limited by the number of doses. But the rollout is based on the same equitable basis, that okay, if you are above a certain age, you get it. Now, what Dr. Razvi was mentioning again with the vaccination, I'm also very much perturbed by that. The prioritization of who gets the vaccine has been left to the people. So if you can pay, you get the priority. If you can stand in the queue, you get the priority. Or whom you know, if you know the right person, you get the priority. Now, these three things help you to control a pandemic. What helps you is if you are more exposed, if you are more at risk, and if you have more comorbidities, and if we target those people, then we can control the pandemic through vaccination. Otherwise, I don't think there is much point in just doing it in a haphazard way, because doses will always be limited. So again, it boils down to the same thing, that when in peacetime, or when we have time, or when even now, we are doing firefighting. This is proper firefighting, where we are throwing water right, left, and center. And once we are done, once the fire goes away, because the fuel goes away, it's not that we have controlled the fire. We are waiting that the fuel, which was actually propelling the fire, like we're waiting for that to die down. So when that dies down, then we will just see what is left, and we'll start building. So even now, we are not preparing ahead what we are going to do 6 months down the line. Just to give you the last example of that, UK just ordered 60 million new doses for vaccines. I think preempting that we might have to give some booster doses, given the fact that we already had vaccinations. And if you compare it with what India did, in India, we did not order vaccines till December, even to Serum Institute. I mean, just think of that huge, colossal mistake. How is a Serum Institute expected to ramp up capacity beyond the orders given by the government? They cannot, because they are a business, and they're not supported financially either. So, and whereas in UK, in US, even US, despite Mr. Trump being at the helm of affairs, they had ordered vaccine doses which were needed for the entire population back in July. Maybe even before that, they were booked. So what I'm trying to say is, even now, while we are firefighting in India, we definitely need to put our heads together and plan for what we expect based on evidence, what we are seeing, what we expect is going to happen 3 months, 6 months down the line. And what are those key things? Again, the triaging comes in. What are those key things which are going to start saving lives? Otherwise, we will be repeating the same action plan, what we are doing now, to me, which is a bit messy. Sorry, I went on a rant.
No, thank you. I think a lot of us feel the need for a rant. What I would like to invite Harun to ask his question there. But while he's doing that, can the panelists please formulate a sort of 2-minute wrap up of their thoughts, in particular about action plans for the EU and India, please? So Harun, thank you for joining us.
Thank you.
I know you've worked a lot with triad systems and about how they're useful. So please go ahead.
Yeah. Look, I'm going to play the devil's advocate here. Not so much the devil's advocate, but I'm going to come in support of the government here, right? Now, we have spent 1.5% of our GDP for years, right? And yes, we have a lot of wish lists. We need to do vaccination tomorrow. We need to have better infrastructure tomorrow. That's not going to happen. right? Because if you don't spend more money, you're not going to have infrastructure, right? But there is a solution. The solution is we can have private-public collaborative models, right? And that has happened in other places, and that has worked. And the governance system or the private-public collaborative model can be controlled by state governments or central governments. So my question is to Anant, right? So we are working with people like Microsoft. We're working with people like DXC, and we could provide scalable, sustainable systems driven by sustainable business models that provide protocolized care and time-sensitive triaging, and that protocol can be changed in a second, right? So all of that's possible. All we need is government buy-in into a private-public collaboration model that's sustainable. How do we do that? How do we engage the government? How do we engage the NGOs or even the private corporate stakeholders in India to implement such system? Question for you, Anant.
Thanks, Harun. Anant?
Yeah, that's a very tough question, because that's a question which also comes to me almost once a week at least, which is how do we engage the government? And I don't think that there's an easy answer. There's a couple of reasons for that, right? Number one, governments are led by political parties, and the political side of the governance actually dominates a lot of things in India, and not the bureaucracy and the institutions. So I was just thinking a moment ago when Aviral was talking about what happened in, let's say, the US, even under Trump. Even under Trump, you had a state that was that has a robust institutional setup, and I think that we don't have that institutional setup system here in many of our governments, and that's a real challenge, right? So then, opportunistically, what can happen? Opportunistically, I think what really happens is that there are powerful business players. There are powerful universities. I mean, you see, for example, that Tata Trusts has done, even if it was doing something very small, there is a particular moment in Odisha where the government is willing to tackle the housing problem. Tata Trust steps in, a number of civil society organizations step in, and they actually figure out how to make it happen, right? And take for example, Azim Premji University. Over the years, Azim Premji University has always been producing knowledge to be at that point where if an opportunity shows up, it jumps in. And I think that what we need to really do is to strengthen those kinds of institutional connections, which can opportunistically move in when something presents itself. And that's the thing that we need to understand about governments in India, that it is always, given the range of kaleidoscopic possibilities, with something happening in the center, something happening in the city, something happening at the state level, one needs to be always ready to be able to grab an opportunity when it comes, and it could come up anywhere. And so if you ask me, where would you find those stakeholders? I would say you find them in civil society. I would say you would find them in business houses, because those are the guys who are going to be around for the longest time, and they will be able to be the kind of trustees for the capacities that are being built now. That is where our hope really lies. And then, of course, you do need the state to be an important partner in this. I mean, we were just thinking about the number of things that we've been saying about triage, right? Why is it that the triage system doesn't work in India? It doesn't work because if you do the triage, then you have a set of protocols. You need to have the confidence that you can actually follow the protocol and deliver, right? If I do the triage and say, oh, sorry, I can't really follow the protocols because I don't have the capacity, then it's not going to work. Therefore, I'm not going to do anything that formally looks like a triage that is going to result in some kind of a sequential following through protocols. Like right in the beginning of the lockdown, we said we need to know how many people are going to be hungry in a sequence week from now, right? How many are going to be hungry next week? How many are going to be hungry 2 weeks from now? And that was an important question, because different groups of people are going to go into that crisis mode, because they have reserves that are drying up, because they have jobs, right? And the governments were not willing to look at it. Because if we know exactly how many are there and we admit it openly, then it becomes your obligation to deliver. And we don't want to take that risk. We are not confident that we can deliver. So that's what my answer would be, that go for players in civil society and in corporate world who are going to be there with you in the long run, and build from there.
Thank you, Anant. Harun, I think we need to connect with Anant on a separate channel, because he's such a useful person to find out what we can do more about this. I think time is pressing on. I just thought I would mention, even under Trump, Anant, that was probably the deepest cut and the most compelling cut. So yeah, well, we've all said a lot about our problems with how the Indian government is handling. I think the deepest cut was, I would say, even under Trump, it was better in other countries. Dr. Razvi, can you start the process of a wrap up of this session by highlighting one particular point that you want to focus on?
Sure, Umair. So, I don't really think that anyone expects this wave to be the last one, right? But the intensity of the next wave will depend a lot on how well we are prepared for it. And as Aviral really pointed it out really well, that right now we're just firefighting. We're not aiming to douse the fire. We're just trying to put it out with little spots and bits of water. What we really need to do is ramp up vaccinations by an order of magnitude over the next few months. We have to prepare our primary health systems. We have to have the political will to invest in our public health infrastructure. I mean, I don't mean to say that this is going to happen. That would be a miracle, but that's what I would like to happen. We need to ensure that the hospitals have a steady supply of inputs necessary to save lives. It is beyond appalling to see that patients are dying just for the sheer lack of oxygen. And I'm sure it hurts each and every one of us on this panel and discussion. We should aim to, publicize collectively safe COVID behaviors. I don't see that happening much. Right now with the second wave, there is some masking up happening. Some of the population is following, safe behaviors, but it's still not endorsed by the political, by the administration, and it still doesn't come across as a necessity. That really needs to be, some messaging needs to be sent out. I'd also like to reiterate, I don't know whether I was heard in that initial opening when I think I got cut off, but basically an efficient and equitable health system cannot be developed without adequate public health funding. We have to see that. Can the world, can the European Union put pressure on India to increase its, healthcare spends? We have to do that. The COVID crisis is not just a setback, the second wave is not just a setback for India, it's a setback for the entire world. As long as the virus continues to simmer in some part of even rural India, it's going to pose a threat to the entire world. So what we really need to have is a shared social objective, partnerships, global partnerships, which actually look to, eliminating this virus, handling the pandemic, and ensuring that it doesn't spread. Nations have to collaborate. Like I mentioned earlier, the EU has to support the waiver. I mean, there is no question about that. The intellectual property rights have to be waived, and there has to be more support for more countries to manufacture more vaccines. Most of the third world countries have not, I think there are a couple of states in the US which have received more vaccine doses than the entire African continent. I mean, that's just to put things in perspective. That's horrifying. And lastly, what I would really like to table as a point here is there is a lot of aid reaching India, a lot of aid from all corners of the world. Where is the accountability for that? Some of it is still sitting in hangars. Some of it's still, stuck in customs, like some of the co-panelists mentioned. Where is the accountability? There has to be some pressure from the community to ensure that they send supposedly help the vulnerable.
Indeed. Yes. Thank you. I'll invite Raghib now to give his a couple of minutes.
Sure. I know we're almost out of time. I think I would stress again that there is only really one way out from COVID, and we've seen this now in Israel and also in the UK, and that is vaccination. Everything else is really a temporary measure, but vaccination provides the long-term solution here. And it's not impossible for India to do this. I was just reading that in February they vaccinated 110 million children against polio in 3 days. And so, of course, polio is easier to administer than the COVID vaccine, but the AstraZeneca vaccine is relatively easy to store, to transport. It's already being made in India. I hope the US will send their doses that they're not going to use. The European Union has excess doses as well that they're not going to use. So within a short period of time, particularly once we're over this acute phase, I think the number 1, 2, and 3 priority for the government of India, both at federal and state level, is to vaccinate everybody free of charge, and that is the only real solution I feel here.
Thank you. Aviral?
Thanks, Umair. I agree to what Saleema and Raghib just mentioned. So I think what Indian government, if I can say that, needs to do is have a short-term and a longer-term strategy. And in the short-term strategy for effective firefighting and all that, they have to pull in all their resources like last week. So they're already very late, but India has massive army resources. India has multiple resources, from corporate to army to government, a lot of money. I don't think for a second that Indian government lacks financial resources. They are there, but it's just not used in the right place. So a short-term strategy to douse the fire, but a lot more effectively. We have already discussed how that can be done, from addressing oxygen to triaging to so on and so forth. And bit longer-term strategy for what we can do to prevent that 6 months down the line, when the third wave strikes, we are not in the same position. And for that, what Raghib just mentioned about vaccination, right, left, and center. Again, anyone from army to Anganwadi workers to community health workers, everyone is ready to help. But it does need to come a push from the national central government. Vaccination is too important a thing to be left to private players. Not that they are irresponsible, but they don't have that bandwidth. So it's too important a thing to be left even for states, because it has to be a centralized policy with prioritization, everything. So that just mentioned about polio. If polio vaccine costed even 2 rupees per drop, we wouldn't have seen this coverage. I can guarantee you that much. So this one is costing a lot more than that. So that needs to be addressed. And lastly, where I come from, again, communication is the key thing which links all this up. Communication takes away huge amount of panic, takes away huge amount of anxiety, provides exactly what needs to be done in what situations, saves lives. People can go about doing their work. People can go about living their lives. They can stop worrying about their children. There is so much this communication can solve. There are no strategies for the moment. I see there has to be a clear-cut strategy for all the end users, from healthcare workers to public to policymakers to even media. There has to be a very clear evidence-based strategy for that. And for me, that is going to change. All these 3 things are going to give me hope if we want to see a different India in 6 months' time or 1 year's time. Otherwise, sadly, I'm a bit more critical, but sadly, we might be sitting down and talking about the same things in the third wave.
Thank you, Aviral. Anant?
I think I'll agree with everyone that vaccination is the best and the only route that is available to us. We have oxygen problems, we can deal with it. We have medicine availability, we can deal with that. We have beds, we can deal with that. If we make the political commitment at the central level that we want to make sure that the largest number of people in India are completely covered and vaccinated, and say that we will commit all our resources to this. And I'm absolutely convinced that many of these situations are things that the army is very, very well equipped to deal with. They have the logistical capacity, they have the management capacity, they would be able to think through these things. So go with that completely, that a centrally led, offensive, very, very aggressive vaccinating strategy, doing it absolutely at zero cost to the public, without letting the market play a big role in this. That's something that I would wish for. In making that happen, I think that given that we don't really have so much leverage internally on the government, right? And the form of mechanisms and tools that we have to put pressure on the national government from outside are not very clear either. I think the second thing that really needs to happen, and I wish that happens, is that a lot more of these conversations about what kinds of ethics, what kinds of longer term political values do we want to live by need to happen across the board. So in that sense, I mean, even this conversation is something which is very, very important for me in that direction.
Thank you, Anant. I think we're running out of time now, but what an interesting conversation it has been. And in the final wrap up, it was a lot of focus on vaccinations. So yes, we'll see how that can be passed on to bring a lot of pressure to have that centralized directive for vaccination, as Anant was saying, and then communication as a key tool. And Aviral will continue his work with trying to reach out to as many people as possible, and I'm sure everyone will join hands with that, and the partnerships that Anant had mentioned. So all that need to be highlighted. And once this is over, Harun's point about how to improve local resources with having protocols in place and partnering with corporate houses, whatever it takes to improve India's healthcare infrastructure, that would be the focus for us. Thank you very much, everyone, for joining in. And I really enjoyed this conversation. Thank you.
Thanks a lot.
Thank you.
Thank you. Thanks.
Thank you. Thank you.
Thank you, Ali. Okay.